Good afternoon. My name is Paul Wax. I'm the Executive Director of the American College of Medical Toxicology, and I'd like to welcome you all to our weekly webinar series on the medical and public health considerations of COVID-19. Today, we have a very special and timely presentation on a topic of interest to many of us, which is pregnancy in the time of COVID-19. Next slide. I'd like to thank our webinar series partners for helping to get out the word about our webinars. Next slide. This webinar, as well as our previous webinars, have all been put onto our website at acmt.net/COVID-19 web. And today's webinar will be recorded and will be put onto the platform in about 2 days. Next slide. There will be a Q&A at the end of the webinar. This is a big feature of our webinars, and generally this goes on for 15 or 20 minutes sometimes. And please type your questions into the Q&A function during the webinar or into the chat function, and we'll get to as many of the questions as possible. We monitor all the platforms, including YouTube as well. Next slide. We've also developed a series of FAQs based on a number of our webinars. This can also be found on our website. The most recent update was about influenza testing in the setting of COVID-19. Next slide. Our speaker today does not have any conflicts of interest to disclose. Next slide. I'd like to introduce my co-moderator of the series, Dr. Ziad Kazi. Dr. Kazi is a board member of the American College of Medical Toxicology and president of the Middle East and North African Clinical Toxicology Association, and an associate professor of emergency medicine and medical toxicology at Emory University. Next slide. It's my great pleasure to introduce our guest moderator today. Our guest moderator is Dr. Mara Zlotnick. She's the Associate Fellowship Director and Clinical Professor in the Division of Maternal and Fetal Medicine in the Department of OBGYN and Reproductive Sciences at the University of San Francisco, UCSF in San Francisco. And she'll be helping out with the moderation of the Q&A toward the end of the webinar today. At this point, I'd like to turn it over to Dr. Kazi to introduce our speaker.
Thank you, Dr. Wax. Hello, everyone. This is a very important topic that we've been meaning to bring to you for several months. And we have an excellent speaker today to update us on this very important topic. Dr. Denise Jamieson is the James Robert McCord Professor and Chair of the Department of Gynecology and Obstetrics at Emory University School of Medicine. Dr. Jamieson has a tremendous amount of experience, clinical work with our pregnant population, as well as experience in emergency preparedness and public health through her work at the CDC. Dr. Jamieson completed a fellowship in the Epidemic Intelligence Service at CDC and worked at CDC for 20 years in maternal health and emergency preparedness. She has most recently been appointed to the National Academy of Medicine. Dr. Jamieson is going to discuss a broad number of questions related to pregnant women and COVID-19. Dr. Jamieson?
Finally figured out how to get off mute. So thank you very much. I appreciate the invitation to speak. Before I started, I also just wanted to thank my long-term friend and collaborator, Dr. Rasmussen. We have worked together on many infectious disease and pregnancy issues for more than 2 decades now. And what I'm going to present today really represents our joint thinking on this topic. So I'm going to ask a series of questions and then present the evidence to help answer those questions. And the first question is, are pregnant persons more susceptible to becoming infected with SARS-CoV-2? Are they more likely to acquire COVID-19? And the answer is, we don't know. We know what the prevalence in certain pregnant populations are during certain periods of time, because we instituted universal screening of pregnant persons presenting to labor and delivery at many of our sites. And these are a number of different published reports that demonstrate that the seroprevalence can be quite high, or the prevalence rather can be quite high, up to 20% in some settings such as New York. However, we do not have a comparison group. We're not doing universal screening of other populations, so it's very hard to say whether pregnant women are more or less likely to acquire COVID. Second question is, how do race and ethnicity and other factors affect SARS-CoV-2 infection in pregnancy? This was a nice analysis that looked at prevalence rates of SARS-CoV-2 infection by different characteristics. And they showed that, and this is in New York City, they showed that infection was less likely among persons living in buildings with higher mean assessed values, building with more residential units, neighborhoods with higher income, and it was more likely in neighborhoods with high unemployment, large households, and more crowding. This was an analysis that we did here at Emory, and we have 2 hospitals that are less than a mile away, yet have very different patient populations. Grady is our hospital that serves largely an underserved population, all Medicaid or uninsured, almost nearly all Medicaid and uninsured patients. And the prevalence there was 9.4%. At the same time, we measured the prevalence at Emory University Hospital Midtown, which is primarily uninsured population, and the prevalence was 1.5%. Infection was also significantly associated with Hispanic ethnicity, uninsured status, high neighborhood density, and paradoxically, smaller household size, which is not what we would have expected. Can't really explain that. But for the most part, infection was associated with more crowding and lower socioeconomic status. So the next question that comes up are pregnant persons with COVID at increased risk of severe disease compared to non-pregnant persons? And the answer here is basically yes. So these are the best data. This is an updated report from the CDC case surveillance system. And it looked at pregnant persons with COVID compared to non-pregnant patients with COVID, and found that pregnant persons were more likely to be admitted to the ICU, require mechanical ventilation, require ECMO, and die compared to non-pregnant persons. And that was after adjustment for important covariates, age, race, and medical conditions. Similarly, or I should say, this is similar to non-pregnant patients. We also know that pregnant patients with comorbidities are more likely to have severe disease. So this was a prospective population-based cohort study from the United Kingdom, and it was a very nicely done surveillance system. They actually set it up in 2012 in anticipation of a respiratory pandemic, and then they didn't activate it until COVID. So they had done a lot of the groundwork for their surveillance system prior to COVID. This was a report that they published in June on 427 pregnant persons. And what they found was risk factors for severe disease defined as hospitalization, which isn't perfect, but it's a measure of severe disease, that patients who were Black, older, and overweight or obese were more likely to require hospitalization. The other thing that I wanted to point about symptomatology, this is a registry that was set up and led by UCSF. This is a nationwide prospective cohort study of pregnant persons in the US called Priority. And an interesting finding from this report is that a quarter of symptomatic participants, pregnant participants who were positive for SARS-CoV-2 had persistent symptoms 8 or more weeks after symptom onset, which is certainly concerning. So now I want to shift and talk a little bit about pregnancy outcomes. Does COVID-19 affect pregnancy outcomes? So if you think about infections in pregnancy and the effects on the embryo or fetus, you can have direct effects of the pathogen on the fetus. So in cases where the pathogen is transmitted intrauterine or in utero, things like Zika, you can have direct effects on the fetus, but it's also possible to have secondary effects due to maternal illness. So for example, we know from our experience with pandemic influenza in 2009, persons with severe illness were more likely to deliver preterm infants, low birth weight infants, and infants with low APGAR scores. So severely ill pregnant women are more likely to have preterm birth, for example. So what does it look like with SARS-CoV-2 infection? Is maternal COVID-19 associated with preterm birth? These are a number of studies. Some of them show an increased risk. Some of them don't show a risk. But I think taken as a whole, there's probably an increased risk of preterm birth. And this is from a systematic review of 30 reports that was published as a living systematic review. So it's supposed to be continuously updated, published in British Medical Journal. And this did show that there was an increased risk of preterm birth, about 17% among COVID positive compared to those without COVID. And it was a threefold increase, an odds ratio rather of 3. Now, whether this is due to direct effects of the infection or maternal illness or even iatrogenic is not entirely clear, but they're taken in whole. There does seem to be a suggestion that there's an increased risk in preterm birth. What about stillbirth? Stillbirth is even harder to, it's luckily less common, harder to study. There might be some suggestion of an increased risk of stillbirth. That UK system surveillance system that I mentioned before, they found that during COVID, among COVID positive, there was an increase, there was 12.1 per 1,000 stillbirths compared to their national baseline rate of 4 to 5. For one hospital, there was a report in JAMA of 9.3 during the pandemic period and 2.4 prior to the pandemic. Although these both suggest that there may be an increased risk of stillbirth, I think the jury's still out and it is not entirely clear. So in the press, there's been also a lot of talk around overall preterm births during COVID lockdowns. And there have been some stories about, where are all the babies in the NICU during this period of time? And is there a decrease in overall preterm births, not among COVID infected, but among all births? And it's remarkable that in Ireland, Denmark, and Netherlands, there does seem to have been a rather dramatic decrease in preterm births. And the differences are mostly due to a reduction in the extreme prematurity. And people have postulated, is this due to decreased stress or increased family support or avoiding other infections, getting better sleep, having better nutrition, decreased stress, decreased exposure to air pollutants, avoidance of financial strain in these settings, which seem to me to be very different than the United States and the stress that we're all seeing from COVID lockdowns. But it's really interesting because the causes of preterm birth have been elusive for decades. And if we could really figure out a way to prevent preterm births, that would be remarkable. The bad news is that when we look at the preterm birth rate, there was a report from two Penn hospitals, pre-pandemic versus pandemic periods. There was no change noted in the United States. So very interesting. I have no idea what this means. So the next question, let's talk about, is there intrauterine, intrapartum, or postnatal transmission of SARS-CoV-2? And the answer here is probably yes and probably. So various systems have been proposed to determine whether or not intrauterine transmission, transplacental transmission occurs. I like these Blumberg criteria, which basically say the mom's positive, there's evidence of early exposure, and then there's persistence of infection. There are different sets of criteria that have been proposed. WHO is also working and proposing a set of criteria that I hope we will adopt. So there are cases in the literature that meet the Blumberg criteria and seem to be possible or probable cases. I won't go through the details of these, but this is one. And this is another that I feel is one of the more compelling instances where it seems as though intrauterine transmission occurred. This was a mother who had a cesarean delivery. The membranes were intact. The amniotic fluid was PCR positive. The placenta was positive. The neonate was resuscitated, intubated, and isolated, so no contact with the mother. The neonatal blood and bronchoalveolar lavage fluid was PCR positive. The neonatal nasopharyngeal and rectal swabs were persistently positive. The neonate had symptoms and then gradually recovered. So to me, this is a probable case, and there are maybe 10 to 15 cases in the literature that seem fairly compelling. The next question is, can it be transmitted through breast milk? So there have been numerous papers that test breast milk from infected mothers, and there's they are PCR negative. There was a case series with 18 pregnant persons, 64 samples collected. Only one of them was PCR positive, and there was no replication competent virus detected in the milk. However, so that would seem to indicate that if it gets into the milk, it doesn't get in very efficiently, if at all. This was a case report where a mother had mild symptoms. She was breastfeeding. Per the report, she wore a surgical mask and used very careful hand and breast hygiene, so it was unlikely to be contamination. The breast milk was tested 7 times and was PCR positive on 4 consecutive days. The timing lined up, so the baby developed symptoms and tested positive for both SARS-CoV-2 and RSV. So possibly this was infection. The baby very likely could have gotten infected from maternal contact or any other contact as well. So taken as a whole, is it possible, maybe, that you can get breastfeeding transmission? But this study was very reassuring. This was an observational cohort of 116 COVID positive mothers in New York City. All the moms breastfed, including using a surgical mask, careful hand and breast hygiene. All the infants roomed in with the mothers, and all the neonates were negative. So I think in terms of our messaging about, is it safe to breastfeed? I think the answer is the risks, the benefits of breastfeeding probably outweigh any small risks of transmission. So the next question I'm going to move on to is vaccines. Can pregnant persons receive mRNA vaccines? And obviously, the past few weeks have been very busy with lots of developments in the vaccine front. So I was just going to review what happens normally in terms of vaccine approval. So in general, you have these preclinical studies that are performed. These include, for vaccines used in pregnancy, these include DART, or developmental and reproductive toxicology studies. Then you would apply for an IND, an investigational new drug application. And then there are phases of clinical trials. People talk about phase 1, 2, and 3. Phase 1 is primarily safety, 2 is effectiveness. Phase 3 is safety and effectiveness. These can sometimes be combined. And then once you have enough, you being the manufacturer has enough information, a BLA is submitted, which is a biological license application, or an application for full licensing of the product, the vaccine. That's reviewed by the FDA. The FDA would approve the new vaccine. And then the ACIP, which is the Advisory Committee on Immunization Practices, it's an advisory committee to the CDC. They would meet, make a determination. Once they determine that the vaccine, basically they determine how the licensed vaccine, who gets the licensed vaccine and how, and they would make their recommendation to the CDC director, and then it would be approved for use. And then there would be phase 4 is the post-approval monitoring and research. So that's the full licensing. There's been a lot of talk about, were there shortcuts for approving this vaccine under an EUA? So I wanted to explain a little bit about the process and explain why I think that it wasn't a shortcut. I think it was a responsible, thoughtful, careful way of evaluating information quickly and ensuring that the product that's available is safe. The products, hopefully, that are available are safe and effective. So the steps, and I'm going to specifically comment on what the process was for pregnant persons and the mRNA vaccine. So first you have the DSMB. I have all the acronyms here because I realize there are tons of them, which is this Data and Safety Monitoring Board. Is composed of independent scientists who periodically review phase 3 clinical trial results. So they look at the data and say, oh, we have enough outcomes, we're going to stop the trial. Or we're going to continue the trial, but we're going to apply for an EUA. An EUA is an emergency use authorization that's submitted to the Food and Drug Administration. And this is the authority that's provided to the FDA to allow medical products to be used in a public health emergency. And with these vaccines in particular, the FDA set higher standards for the vaccines, given that they would be used on large populations of healthy people. So they actually said, yeah, you need phase 3 trials before we'll consider your EUA. Data are then reviewed by career scientists, so the regular staff at FDA who have tremendous expertise in this area. And then it's reviewed by VRPAC. VRPAC is the Vaccines and Related Biologic Products Advisory Committee. VRPAC is an independent committee to the FDA, and it provides sort of an independent look at the data. And that's done before FDA approves the EUA, which is what happened, is it last week? Last week now. Once the EUA, so the FDA met on, I forget if it was Thursday or Friday, I think it was Thursday, and they're meeting again tomorrow about the Moderna vaccine. Once that happened, then the ACIP had an emergency meeting. The ACIP, as I mentioned, is that advisory committee that advises CDC. It's an independent committee. It reviews the EUA and provides recommendations for how to use the vaccine for populations to be vaccinated and makes a recommendation. Once they make their recommendation, it is approved by the CDC director. And then the next step, it's really important, is in our field, is that professional organizations such as ACOG and Society for Maternal Fetal Medicine issue guidance to help guide obstetric providers in vaccination. So the ACIP met on Saturday. On Sunday, ACOG issued a practice advisory alerting obstetricians as to how to manage vaccines in pregnancy. And then on Monday, the first pregnant women started getting vaccinated in the US with the Pfizer vaccine. So very exciting. So how do mRNA vaccines work? mRNA vaccines basically carry genetic information to manufacture the spike protein, the protein on the virus surface of SARS-CoV-2. It gets injected into the muscles. The cells manufacture the spike protein. The spike protein is recognized by the immune system, and the body mounts an immune system. The mRNA is rapidly degraded. It has to be kept very cold because it's so unstable. And so within days, the mRNA is degraded. It's removed by the lymphatic system. It never enters the nucleus or is integrated into the cell DNA. So there's been some talk, could the vaccine, could the the nanoparticles with mRNA reach the placenta and cross the placenta? But given how mRNA vaccines act locally and are rapidly degraded and removed, it's very unlikely but possible that the vaccine would reach and cross the placenta. And so that's been the major safety concern. So what do we actually know about mRNA vaccines in pregnancy? Well, Moderna, the manufacturer of the vaccine that's being reviewed this week, released preliminary results from developmental and reproductive toxicology studies from rats, basically showing no concerning effects, and FDA has looked carefully at these data. In addition, although pregnant persons were excluded from all the clinical trials, there were pregnant persons inadvertently enrolled in the clinical trials, which always happens for a variety of reasons. There were 23 pregnancies in the Pfizer trial, 12 in the vaccine arm, and 13 in the Moderna trial, 6 in the vaccine arm. I am hoping that and the manufacturers have indicated that their plan and intent is to start enrolling pregnant persons in mRNA vaccine trials, hopefully early this year. And then the other piece that I wanted to mention is safety monitoring. So there are a number of systems that are monitoring safety in all persons and specifically in pregnant persons. And one of the exciting new developments is the CDC Be Safe system, which if you're lucky enough to have gotten your vaccine already, you should have been given information about CDCs Be Safe. CDCs Be Safe is a new phone-based vaccine tracker for monitoring side effects in vaccine recipients. You sign up on your cell phone, and then you follow up. And CDC follows up with you, and this V-Safe system is specifically capturing information on pregnancy status and allows for follow-up of pregnant women. And I hear from my CDC colleagues that pregnant women are have already registered in this system. So we should know more soon. So I mentioned that ACOG, American College of OBGYNs, came out with a practice advisory on Sunday evening. And this is what is recommended per ACOG. It also aligns nicely with Society for Maternal Fetal Medicine. So people who should get the vaccine should be offered the vaccine regardless of their pregnancy status. Pregnant persons should be encouraged to talk with their obstetrician about their vaccination plan, but health systems should not require this for vaccination. We don't want there to be logistical barriers that limit access of pregnant women to get vaccine. And persons planning to become pregnant and are recommended to get vaccine should really complete their vaccination series prior to conception. It's just like any other vaccine. Before a woman gets pregnant, ideally we want to ensure that all her vaccinations are up to date. And I would argue in this day, having your COVID vaccine, if you're in a risk group, is high priority. So if you're not pregnant yet, get vaccinated before pregnancy. Pregnancy testing should not be a requirement for vaccination. Again, we don't want to limit access unnecessarily. And there's no reason that lactating persons shouldn't be offered the vaccine. We give live measles, mumps, rubella vaccine to lactating women postpartum. And there is no reason why this vaccine shouldn't be offered to breastfeeding women. One caveat, you always want to remember to treat fever in pregnancy. Following vaccination, fever is common, although not as common as it seems to be if you read the news. It's about 4% after the first dose and about 16% after the second dose in younger people. It's less common in older people. Since we know that fever in the first trimester can increase the risk of certain birth defects, you want to treat the fever with acetaminophen, but you should not be taking acetaminophen prophylactically for a couple of different reasons. So I think this is my last question, and that is, what should pregnant women do to avoid COVID? Well, pregnant women should really be doing what all of us should be doing, which is summarized as the 3 W's: wear a mask, wash your hands, and watch your distance. Avoid crowds, avoid COVID. Do what you can and stay vigilant, because the end is relatively near. And so, I think everyone is really fatigued and tired, but it's really important more than ever, and with the holidays coming up, that people be careful. I have 2 14-year-old twin boys who basically have driven me crazy for 9 months, because the poor kids are on Zoom all day and they're bored out of their skulls. And there's all sorts of things that they want to be doing that they can't do. So rather than continuing to tell them all the things they can't do, I realized that I had to come up with a plan and come up with rules for what they could and couldn't do. So we refer in our house to these 4 rules. And every time they ask me something, I ask them what rule it falls under. I tried to make the first 2 positive, because I got so tired of telling them no all the time. And these may not align exactly perfectly with CDC or other guidance, but I tried to make it practical, and I tried to focus on the things that were most important to them. If you look at number 3, I clarify eating, but only outside. I think inside eating is a huge problem, and there's some data to support that. There is nothing that says that eating 6 feet apart is safe. Inside is safe. And so I really tried to focus on staying outside. So in conclusion, no data on whether pregnant persons are more susceptible compared to non-pregnant. Race, ethnicity, insurance, and neighborhood factors affect whether a pregnant person is infected with SARS. Pregnant persons are more likely to have severe disease, and the risk factors are similar in pregnant versus non-pregnant persons. In terms of effects of COVID on the embryo or fetus, there is likely an increased risk of preterm birth. Whether this is a direct effect of SARS-CoV-2 or an indirect effect is unclear. Not sure about stillbirth. I think really the jury's out. I believe that intrauterine transmission occurs and has been documented, but it's not common. And pregnant persons can be safely offered the mRNA COVID vaccine. So thank you very much for your attention. I know I covered a lot of ground, and I'm happy to take questions. Thank you.
Dr. Jamieson, that was so wonderful. You gave us a lot of really important and practical advice, and I think you answered a lot of people's questions that were typed into the chat as we went along, but we are still getting in lots of questions. So I think the first question for you would be, there's a theme of what should women do approaching their due date? Should they quarantine for a certain amount of time when their due date is coming up? How should they address sort of, if they're following the rules that you've already laid out for us, what should they do when they're coming up on their due date?
So the question may be, so I think it depends on what you do and what your options are to minimize your risk. So the questions that I get a lot of are healthcare providers. Should a healthcare provider stop working? It's interesting because providing healthcare, even in a COVID unit, is not your biggest risk factor. Most transmissions occur in the community. And furthermore, most of the transmissions that we've seen in healthcare systems have been in break rooms where people are eating. So I'm not sure. So I think that pregnant women approaching their due date should be vigilant about not getting COVID. And I don't think that means that they have to stop working necessarily. I think they just keep doing the same good things they should be doing throughout pregnancy.
So I think you've just answered this question, but are there special precautions you'd recommend for frontline workers who are pregnant, as far as PPE or other things?
I would recommend doing exactly what you normally do with for PPE, and to do it correctly and consistently. This is not a super transmissible pathogen. We know how to protect ourselves. We just have to do it consistently and correctly, and realize that most of the transmissions now are occurring in the community, and mostly in households. So that is the major problem. And just the issue about PPE. PPE is really interesting because there's an undocumented story, and I have tried very hard. Unfortunately, the people involved in the story I've talked directly to, but they've never written it up. But basically, and it's been a while since I thought about this, so I might get it wrong, but in Texas, there was Ebola transmission of 2 healthcare workers. And at the hospital, actually it wasn't the index patient came in. No one knew for sure that the patient had Ebola, came into the emergency room, and was taken care of by several emergency room nurses who were veterans, who knew exactly what they were doing. They didn't know they were dealing with Ebola, but they took appropriate precautions. And at the time, in retrospect, the patient was highly viremic, so highly infectious. He then went from the emergency room up to the ICU, now diagnosed with Ebola. And the 2 junior nurses who were just out of, who had not had that much experience, took care of him and made alterations to their PPE. So if 1 pair of gloves was good, they thought 2 was better, and they taped the gloves and made other alterations to their PPE, thinking that they would be more safe, and they got infected. And so what I took away from that story is, do what you do. It's like condom use. Do what you do consistently and correctly, and don't make alterations, and don't change what you do. Just do it, do it the way you should be doing it.
Wonderful, thank you.
And as just an editorial aside, because now I don't work for the federal government and I can say any crazy thing I want, is that COVID is a lot like a sexually transmitted disease. I mean, it's the same, who you eat with, you're also eating with all the people that they ate with previously. You're taking on the risks of that person plus a whole lot of other persons. Your PPE is, your mask is like, using a condom correctly and consistently. And there's stigma. I mean, I struggle a lot as the chair of a OBGYN big clinical department. There's a lot of stigma now because people say, well, what did you do? How did you get it? And so I think we need to avoid that stigma, stigmatizing people with COVID.
That's such an important point about the stigma, but also the STI, if your bubble is only 4 people, but somebody in your bubble has another bubble and their bubble has 6 people, pretty soon your bubble's pretty big.
It's actually that piece that I did for my kids where I said, enjoy your bubble. And then not only were they upset that none of their friends were in their bubble, but then they were upset because none of our dogs were in the bubble either. So I had to amend it and say the dogs were part of the bubble.
So we've got a few questions on gestational age, and most of these questions focus on sort of the first trimester specifically. So does the severity of the disease correlate to the stage of pregnancy? And does having a first trimester COVID infection increase your risk of preterm birth?
So we don't have enough information to really sort out trimester of pregnancy and the effects in each trimester the way we have for other pathogens. Hopefully we will have more information. Preterm birth seems to be more common among, and this is consistent with other pathogens, among women infected later in pregnancy and who are severely ill. And so it's probably this indirect effects of when, mom is ill, severely ill, she's more likely to have a preterm birth. And we know that from lots of other infections.
Great. We've got some questions about the medical complications associated with COVID. So what about, are you seeing more preeclampsia, more gestational diabetes, more thromboembolism?
So there's been some reports of increased preeclampsia and some reports that have not substantiated that, so I'm not sure. Same thing with the thrombotic disease. We really haven't seen that pregnant persons compared to non-pregnant persons, it hasn't been adequately examined, but we don't have any strong evidence currently that thromboembolic disease is more common over and above your risk from being pregnant.
Okay, okay. Some questions about management of delivery. So if you've got somebody infected and ill with COVID, she's on oxygen and needs to go to the ICU, how do you weigh decisions about when she should be delivered? The questioner is hearing stories about women decompensating sort of as they're pushing the baby out.
Yeah, it really reminds me some of what we saw with pandemic influenza, where we had women, very severely ill women. And I think it's what we do, as you know better than I do, as being a maternal fetal medicine specialist, it's weighing, how stable the mother is, and for each individual mother, what the risk of delivery is and what the best route of delivery is. And I don't think there's one answer. In general, for a woman who is severely ill and intubated can safely deliver vaginally in many cases. So you just want to, it's an individualized clinical decision.
Great. We've got some questions about sort of maternal infection and breastfeeding. So I think you've sort of explained that a breastfeeding woman can definitely get the vaccine, but what if a woman has had COVID? Do we think that then breastfeeding her baby is going to protect her baby? Has anybody been studying, looking for IgA antibodies in breast milk?
I've not seen any published reports. However, we know the benefits of breastfeeding are broad, and you would assume that there would be protective antibodies that would be transferred to a baby. And I don't see any reason why COVID would behave differently than, or SARS-CoV-2 would behave dramatically differently than most other pathogens where the mother mounts an immune response, antibody response.
Okay, okay. And then sort of related to that, if somebody has just delivered and has a newborn baby, what are your recommendations as far as the bubble at that point? I think prior to the pandemic, it was a time where definitely the grandparents were coming to visit, or maybe an aunt and an uncle. What's your advice there?
I think until everybody's vaccinated, I think you have to think really carefully about who's in your bubble. And if you have a newborn baby, I think it's even more important to worry about who's in your bubble, because every person who comes into contact with the baby and with you is potential, as a nursing mother, is potentially a source of infection. So I think, after you take your baby home from the hospital is a really good time to limit who's in your bubble. And, there's certainly a lot of people who've been very worried about the social isolation for postpartum women and the risk of increasing rates of postpartum depression. And I do think it's something we need to monitor and be careful about, and think about ways, think about a pregnancy plan and a postpartum plan to make sure that the mother is not as isolated.
Okay, great. Well, the questions are still rolling in, so if you can stay with us. So we've got some questions about the so-called COVID long haulers, or the people who've had kind of a chronic sequelae of COVID. Is there any data about this in pregnancy or association with complications of pregnancy?
So that's why I mentioned the priority study, because that is the best data I know of follow-up data collected routinely, systematically from women who are not hospitalized. And what it looks like is the symptoms persist Whether they're going to be categorized, fall into the category of long haulers, I don't know. But there's certainly a concerning proportion of pregnant persons who have persistent symptoms. And I think hopefully Priority will continue to be supported and continue to follow that cohort. And there are other cohorts as well to find out more about what this looks like long term.
We have a question from somebody who I'm guessing works in the ICU who asked, do you have any knowledge or reports about how to best prone patients if necessary during pregnancy? And do you worry about increased risk of vascular collapse due to increased intravascular volume?
So the proning is an interesting question because there is some information that proning can help with COVID infection. And SMFM has a nice picture on their website of how to prone a sort of modified prone position for a pregnant patient. What was the other part of your question, the second part?
Vascular collapse due to sort of expanded pregnancy, intravascular volume, and decreased systemic vascular resistance.
So I think the issues of critical care in a pregnant patient there isn't anything dramatically different than what we normally see. And so you definitely want, in addition to ICU care for a critically ill pregnant person, you also want to consult with a maternal fetal medicine specialist, which I am not.
And I have heard, I'm not a big TikToker, but apparently TikTok is a source for lots of quick videos on how to do things like prone pregnant people. So that's one resource for people in the trenches. So we've got a lot of questions in the chat about the vaccine. And I think this is really still just people, you said kind of, we have limited data so far. Theoretically, it should be safe. But I think there's still a lot of, discomfort with it. Particularly, we've got some people responding saying, hey, in my job, I'm fairly low risk. Whatever it is that I'm doing, I'm not super high risk for getting COVID. Should I get the vaccine? How do you answer that question?
I would say at this point in the pandemic, nobody's low risk. I mean, the rates of infection are sky high. We are all at large risk, regardless of what we do. And so, my parents are in their mid 80s and they have been home since the middle of March and have not left their house except to go for short walks and avoid other people. They're at very low risk. They need the vaccine so that they can get much needed social interaction. Most of us who are out and about in the world are not at, regardless of what our jobs are, we are at relatively high risk. And so I think it's really important to get vaccinated. I think the other good reason is so that we can get back to normal life. And we really need herd immunity. We need enough people in the US to get vaccinated so that we can be done with this for a while, or done with it forever, hopefully. Or nearly done with it, have it be controllable. But at the same time, there are a lot of people for a variety of reasons who are hesitant of the vaccine. And if you are pregnant and you're not comfortable taking the vaccine and you weigh the risks and benefits and for you, it's not the right answer, we should also support pregnant women in declining the opportunity to get vaccinated. And the other question that comes up is, can my workplace mandate me to get vaccinated? My understanding that unlike flu, we cannot, because it's under an EUA. As long as it's under an EUA, no one can be forced to get vaccinated as a requirement for their job.
Are there any people, say, who have certain kinds of immunodeficiencies or allergy histories that you would, based on their medical history, recommend they not get the vaccine?
Yeah, there are groups who should not be vaccinated. And that's one of the reasons for ACIP very specifically outlines which groups cannot get vaccinated. If you've had anaphylaxis to any of the components of the vaccine, you should not get vaccinated. If you are have an autoimmune disease, you can get vaccinated. So there are a few contraindications to vaccine, and they are listed in the ACIP materials.
Okay, they're still coming in. So with the UK reporting a new strain of COVID-19, do you think the vaccine will be effective here?
I do not know. I have not seen, I've not seen how different the strain is in the UK, and I don't know about the safety and efficacy of the vaccine.
And while we're on sort of the biologics of the vaccine, one person asked, is there any concern that the fetus's immune system would identify the spike protein as a self-antigen?
So based on what we know about the vaccine, the spike protein is similar to the COVID spike protein. And we know that there is very little transplacental transmission, but there's no reason that the spike protein, which is a small component of the COVID spike protein, would be problematic to the fetus. So there are two concerns. There have been raised two concerns that I've heard about the vaccine. One is that the mRNA is going to, nanoparticle with the mRNA is going to cross the placenta. As I said, that's very unlikely given how the vaccine works. It's a local mechanism of action. It's not systemic. So you'd have to escape the lymphatic system. It would have to get into circulation. Then it would have to get across the placenta and get to the fetus. It's possible. There's apparently a study that I can't find. So if anybody knows of it, please send it to me. There's apparently a influenza vaccine study that shows that the vaccine can cross the placenta and get into the placenta and into cord blood from several decades ago. But again, we know that we have decades of experience with influenza vaccine, and we know it's very safe in pregnancy. In fact, my fun fact is, do you know what year the Public Health Service, the Surgeon General, first recommended that pregnant women received influenza vaccine? Any idea? 1960.
Wow.
So we've been giving flu vaccine to pregnant women for a long time.
So the mRNA is injected into the muscle, and then the muscle cell's machinery generates that fragment of the spike protein. Is that fragment of the spike protein then released into a person's bloodstream where the immune system interacts with it, or does the immune system enter the cells and interact in that way?
So I'm not a vaccine expert, so I will just say that my knowledge is limited, but it produces a local immune reaction and then production of antibodies, which help, systemic antibodies, which then help provide protection, long-lasting, well, moderately, we don't know how long-lasting, but, relatively long-lasting protection, immune protection from SARS-CoV-2.
Okay. Have you seen any research about, the risk of sort of preterm birth and pregnancy complications? Is any of that been associated with either women who are undocumented, who've been afraid to seek prenatal care, or women who, may well be US citizens, but don't have health insurance coverage and so aren't getting the medical care that they need? Are any of these things being associated with some of the complications?
So so I'm not sure I have the information to answer that. So the studies that show or don't show a risk of preterm birth are among women who are in the hospital identified as being COVID positive. And then we have birth outcomes from them. And then you compare them to either a contemporary group who's also delivering and doesn't have COVID, or historical controls, or baseline rate of preterm birth. So I think the larger question is, are we seeing an overall increase, decrease, or no change in preterm birth due to the lockdowns? And I think that's more along the lines of what other factors could be associated with reluctance to come to the hospital. But I don't think, at least so anecdotally, I don't know that there's been an increase due to those other factors and coming in late.
What are you recommending in the time of COVID for pregnant women as far as certain types of preventative health care, say dental care, that you would normally, outside of COVID, say, yes, you should do this while you're pregnant? I mean, obviously, if you normally would say don't do it, then presumably you're going to say don't do it with COVID. But what would you say about things like going to the dentist while pregnant during COVID?
Interesting you picked dentistry, because that one I have a little bit of concern about. But in general, I think we have figured out during COVID how to safely deliver in-person care. And there hasn't been knock on wood, there haven't been a lot of infections in healthcare settings that are taking appropriate precautions. So I think it's safe to get prenatal care visits as long as hospital systems and physicians' offices are doing what they need to do, socially distancing, not having people in the waiting room, staggering appointments, cleaning between, universal masking, doing all the things that they should be doing. So I don't think it's a reason to skip important preventive care. The issue that we're seeing is with the hospital beds and intensive care units filling up. It might not be time, it is not time right now to do elective inpatient procedures, pregnant or non-pregnant. Dental care is a little tricky because it's hard because, dental care requires you to open your mouth. Although I have to say there haven't been outbreaks that I've heard about that are specifically related to dental offices. The other issue is telehealth. Can you do telehealth? There are some nice models out of Mayo Clinic, even outside of COVID, that show that some of what we do in prenatal care probably doesn't need to be done in person. It probably can be done with a home blood pressure cuff and a fetal heart rate monitor to document heart tones and telehealth. I think we've all learned a lot about how well telehealth works for appropriate types of visits.
Thank you. Do you have any information on the Chinese-made vaccine Sinopharm?
I really don't. I've been so focused on the US vaccines, I really have not been following. One interesting thought about vaccines in other countries, the Pfizer vaccine, particularly in other countries, UK came out and said that pregnant women, pregnancy was a contraindication to vaccine, and I believe they're still not vaccinating pregnant women. Canada, by contrast, is giving the vaccine, started giving the vaccine to pregnant women.
Okay. Do you have any recommendations for outpatient care and things like baby aspirin to decrease the risk of blood clots, or should pregnant women have an oxygen monitor at home?
Yeah, my feeling is that I think we should care for pregnant women in the same way we care for non-pregnant women with COVID, except where there's a compelling reason to do something different. And I don't see any of those as having compelling evidence at this point to do anything different.
Okay. We've got a couple questions from providers who care for pregnant women. So I think people are wondering if the labor and delivery suite acts like an emergency room, should those providers be considered frontline providers and be in an early wave of vaccination?
Boy, that's from my perspective, absolutely. I think that labor and delivery units are unpredictable settings where we have, depending on where you are in the pandemic, there are lots of COVID infected patients. We can't cohort them. We can't put them, in most cases, we can't delay their, delivery. We can't delay their procedure. It's not having a baby is not elective when you go into labor. So it's unpredictable in that, we're running around trying to have women deliver. It's hard for a woman to wear a mask consistently while she's pushing. We know that labor, I won't get into the whole aerosolizing thing, but we know that during pushing, there's a lot of droplets and a lot of respiratory droplets that are in the environment. We sometimes have to intubate unexpectedly for C-sections. And so I think that labor and delivery providers should get vaccine, should be near the top of the list. I think it's a lot riskier than working, for example, in a COVID unit where everyone's, intubated, or if you're going to do an intubation, you can plan for that. So I don't understand why, for example, in many health systems, we are not near the top of the list. I don't know if it's just a fundamental misunderstanding of what it is we do and how we do it. But I'm very frustrated with that.
Okay. It looks like we're getting to the top of the hour. I think we can stay on for a couple minutes to get to a couple more questions. Is that okay, Dr. Jameson, Dr.
Yes.
Wax?
Yeah, that would be great. I think, Doctor, and thank you so much for a wonderful, Q&A. These questions have been fantastic, and the presentation was, truly outstanding. I think Dr. Kazi has several questions, and I have one remaining question as well.
Thank you. I just I'll condense them a little bit. Dr. Jameson, you mentioned that the fact that pregnant women receive the vaccine during the clinical trials is not unusual. Can you provide some more details on that?
Yeah, so often what happens is the pregnancy is not recognized at the time she's enrolled in the vaccine trial. So it's too early in pregnancy, or pregnancy test is not positive, and she's pregnant, or she gets pregnant during the trial. So for example, between the first and the second dose.
Thank you. Now, ACMT is currently conducting some surveillance for adverse events from COVID-19 therapeutics. Are there any therapies for COVID-19 that concern you if used in pregnant women?
So I think it's just like most of what we do in obstetrics, it's weighing the risks and benefits and what we know about the treatment versus the risks of doing nothing. And in general, the principle is don't withhold an effective treatment from a pregnant woman unless you have a really compelling reason to do so. Because the pregnant women should receive, if the pregnant woman doesn't do well, her baby's not going to do well. And so, for example, for most of the, for monoclonal antibodies, we've been using those in pregnancy. There's no theoretical reason to be concerned about their use in pregnancy. For the most part, most interventions should be used in critically ill pregnant women, the same as they're used in critically ill non-pregnant persons, as long as you don't have a compelling reason to change your care.
And then my last question, some of our colleagues are using N95s, others are using different types of respirators, those air purifying respirators called PAPRs when they're working. Would those pose a stress on a pregnant woman's baby?
So the PAPRs can be uncomfortable in pregnancy and constraining in pregnancy. And so during Ebola, there was sort of a move to say that, if pregnant women don't have to wear PAPRs, it might be a good idea. The N95, they're uncomfortable when worn all day. There's some there were some interesting studies that were done that looked at oxygenation levels using N95 masks. But as long as a woman can work comfortably, which many pregnant women are working with N95s, I don't have reason to be concerned.
Since we went through our questions quickly, I have one more question. If you were to do this again, what would you change with our research, readiness for pregnant women in a pandemic?
That's a great question. So we need more investment in public health surveillance systems nationally, and we need public health surveillance systems that focus on pregnant women. Those surveillance systems should live at the CDC. They should be nationwide. You looked at what the UK did. They very quickly got their, hibernated surveillance system up and running. And you look at priority. Vanessa Jacoby at UCSF called me very early in the pandemic and laid out exactly what she wanted to do. And that was precisely what CDC should have had been ready. I said, I'll do whatever I can do to help you because this is exactly what has to happen. And unfortunately, our very talented and skilled colleagues at the CDC do not have the resources and support that they need to do their job well. They know exactly what they need to do. There are really skilled epidemiologists at the CDC who know all about pregnancy surveillance. Just give them the time and the money to be able to set things up properly so that when we hit the next pandemic or the next major outbreak, that they're ready.
I support you wholeheartedly on this topic. Dr. Wax, I'll leave it up to you to conclude.
Great. Well, thank you. Again, thanks to both our speaker and our moderator. Two final questions. The first one is about prenatal care and the impact on COVID-19. We know from our cardiology and neurology colleagues that treatment for patients coming in for treatment for heart attack and for stroke, fell way off, particularly in the spring, with potentially deleterious consequences. What sort of impact on pregnant women getting routine prenatal care have you seen, and has that had any consequence?
I'm not sure I know the answer to that. It's certainly not as dramatic as the delays in care that we've seen in other areas. I think we, at least here in our practice, we figured out fairly quickly how to deliver prenatal care safely. I think a number of health systems decreased the number of prenatal, decreased the number of recommended prenatal visits. And I think it's a testament to the fact that, it's probably important to document heart tones, and it's really important to document blood pressure, but a lot of that we can do remotely. So I don't think we've seen the same delays in care. And I think also women, anecdotally, it seems that women are coming into triage and coming in for pregnancy complaints, regardless of the pandemic. And I think part of that was too, we very quickly said, no visitors, and, we're going to make this space safe. And I think that word got out.
Great, thank you. And then finally, one of your earlier slides was so interesting. The European data about decreased very early preterm babies, not reproduced in the Philadelphia studies. But do you have any further thoughts about that? You'd mentioned that this has been one of the great challenges for many decades to get to a place where there would be a decrease in very early preterm labor. Any further thoughts about what was observed in Europe?
It's really intriguing. I mean, when it was one country, I was like, oh, it's got to be a fluke. And then it was two, and then it was three, and it was fairly substantial declines. So my area of research is not specifically on preterm birth, but boy, there's something there. And it's really puzzling why there would be a dramatic decline in preterm birth. And then the explanations were, decreased stress. And I'm thinking here, there's not decreased stress, there's increased financial stress and increased, and I don't know whether it's, is it environmental? Is it, women are less likely to get other viral infections because they're not out and about? I don't know. It's really intriguing.
Yeah, very much so.
It certainly seems that the places that have reported that are all countries that have good sort of social safety nets, so that the women that are staying at home are staying at home, and they have money to feed themselves and their family, and they're not, I think here in the United States, for people who aren't employed in jobs where they are telecommuting and can stay at home, those essential workers, they're making this really hard choice. Do I continue to go to work and potentially get exposed to this virus, or do I stay home and not feed my family? And so that's obviously going to be a very stressful decision. And I bet it's going to turn out that that's a big part of it.
Yeah, it'd be nice support for providing a better safety net in the U.S.
Well, certainly a silver lining to this awful pandemic is all the knowledge we're learning that will hopefully have a very positive impact for the future. So on that note, I'd like to thank our speaker again, and if we could go to the next slide. Coming up after a short break over the holidays is a presentation about vaccine distribution. We're really thrilled to have Dr. Satish Pillai from CDC. He's the Senior Liaison to Operation Warp Speed and the COVID-19 Vaccine Task Force. And he'll be speaking on January 6th at 3 p.m. during our usual COVID webinar series after the holidays. Next slide. So this webinar has been recorded and will be up on our website. All the registrants will get an email about this on Friday. And we also will have a couple feedback questions. Feel free to send in your comments about this webinar series. We've been really delighted to be able to provide this webinar series this year as a way of getting out important information, and have been very fortunate to have an outstanding array of national and international experts like Dr. Jameson, provide everyone with this very timely information. All this information regarding our prior webinars as well as the upcoming webinars can be found on our prospectus on our website at acmt.net/COVID-19 web. I wish everyone safe and happy holidays in this very distressed time. I think it's gratifying to know that the vaccine is now out. It will be a while still before everyone has access to the vaccine. So please stay safe, observe all the social distancing, public health recommendations, and have a good holiday. Thank you very much and good day.